My presentation is about treatment. Yeah. But we have already heard a lot about treatment, both by all the three speakers. So I will focus a little bit on psychosocial, or the psychosocial approach to such patients, which has been reminded by all of us until now, but I think it is important to address it. So the question is whether you need a psychologist to have a psychosocial approach to OPF patients. Well, in some cases we do need to refer patients when there are signs of severe anxiety, of depression, affective disorders, or in complex PTSD cases, for example. But I think it is quite understandable that psychosocial interventions are part of our approach also as general practitioners in different fields, if it's a physiotherapist or a doctor. So there are psychosocial factors connected to overactive pelvic floors at all levels, both as causative factors in overactive pelvic floor, as we have already seen. Psychosocial factors can be involved in maintenance of an overactive pelvic floor. We have talked a lot about the fear involved. They can also affect the adherence to physical therapy. For example, there are patients who can be so afraid to fail that they will prefer to keep hope and not even try to be compliant with the home exercises. And there are many factors which are related to what happens after we terminate treatment, when we talk about sexuality being medicalized, becoming a medical issue, and losing all its erotic appeal. So when we meet a patient with an overactive pelvic floor, we can use the fear avoidance model of pain, which is used in understanding interaction of fear and pain in many chronic conditions, and adapt it to an overactive pelvic floor in order to understand this vicious cycle. And one of the ways to help patients is to graphically show them, for example, this picture, which is a modification of the vicious cycle of pain, including both physiologic factors and psychologic topics, like functioning in sexuality, relationship factors, emotional factors, and try to go through those links in the chain with the patient and identify where are the modifiable factors for the patient. And that sometimes more than one link in the chain needs to be tackled in order to overcome the problem. Also, a basic description of the gate control theory of pain, which means explaining to the patient that even visually, that thoughts and emotion can impact the way pain is interpreted. So there are both pathways, neural pathways that travel up to the brain to convey nociceptive information, but then efferent fibers go back. For example, if it's a typical a burning flame on the finger, to give an order to pull back the finger, not to get burned, but again, thoughts and emotion have an impact on the way that pain is interpreted, and pain could be increased or decreased according to how we relate to it. There are many patients with an overactive pelvic floor who suffer severe anxiety, and it is not enough to refer the patient to a psychologist, but as most physiotherapists here, or all physiotherapists know, it is important to address such anxiety in order to take care of those patients. So my co-editor on the book, Tali Rosenbaum, who probably is well known to many of you, has developed several techniques based on mindfulness to overcome this anxiety, which have a lot in common with the cognitive behavioral therapy, but they are based on mainly teaching the patient how to attend the pain experience and not to avoid it, but examine thoughts and feelings that accompany the pain. Involving the partner in the treatment plan as a team approach is also very important, and explaining Basson's model of sexual function in women, that spontaneous sexual desire is not required in the female sexual cycle, normalizes that there are many elements that can interfere with the satisfying sexual event. It normalizes also the low levels of libido in long-term relationships, and it assures that the woman can stop the cycle at any time, and it suggests alternative scripts that may temporarily avoid pain and focus on pleasure, and avoid maybe at certain points penetrative sex when it's the source of stress and pain. Now I want to go very fast, very quickly through some things that may be obvious, maybe to most of you, but so I apologize if I sound, very, if I don't take you too seriously about knowing to deal with the childhood sexual abuse survivors. I know that many of those things may seem very basic, but I will anyway go through the important basic approach topics on this, on how to cope with the childhood sexual abuse patients. So we again can learn some tools from interpersonal practice from psychologists, and the approach may include trying to bring the less powerful patient to a greater level of parity and talk about interactions instead of interventions, so that the survivor has the power to influence the plan of care. And distress may not be seen as a psychopathology, but as a coping attempt. It is important to help the patient to connect between her symptoms now and her history. Sometimes the patient is aware, the survivor is aware of her history of sexual abuse, and she's aware of the symptoms she has today, but she's not making the connection between the two. So explain what a somatization disorder is, and that this is a predictable and normal reaction of her body to her past experience. It is important also to discuss the survivor's boundaries ahead, if she can cope, for example, with internal examinations or not, what is a trigger for her post-traumatic stress disorder that can become an obstacle during treatment. And also, of course, talk about the provider's boundaries. What can we do professionally without what is a basic tool that we can't give up, even if the patient has a hard time, and how we can discuss to make it easier for her to go through some examinations. So, okay, this is just very basic bedside manners, but in cases of sexual abuse survivors, they become very important. Always to introduce ourselves by name and status, maintain eye contact, include screening questions on sexual and physical abuse is a big question. I think it's quite well established now that it should be part of medical history. The response to disclosure, when there is a disclosure of sexual abuse, should be calm, non-judgmental, and empathetic. We should ask the patient how the abuse is affecting her or him, that they know better than anyone else, how they handle tests, examinations, blood tests. Use her or his own vocabulary regarding the abuse, document a history of abuse only with their permission, avoid a tone of false intimacy, which is sometimes a way to feel close to the patient, but they can be misinterpreted in those cases. Avoid asking delicate questions while the patient is disrobing or sitting on the examination chair. During physical and pelvic exam, it's a good practice to keep continuous verbal communication with a professional character and keep clear the professional character of the interaction. Difficult examinations can maybe be postponed. A female caregiver can be suggested. A well-lighted private room and knocking always before entering, asking permission to proceed with examination. Before any examination, explain why, how, where, and for how long it is going to take place. Allow extra time for examinations. Allow the patient to prepare in advance and recover. And let her choose whenever it's possible the position on the examination chair. The avoidance of eye contact can remind the patients of the trauma, so it's important to keep eye contact and do not focus only on the genitals. Of course, in gynecological practice, the pelvic exam there are a lot of techniques to make it easier, ask the patient what makes things easier for her. And now, after I've gone through these very important things, I can say a few words, and it's a big jump, but just a few words about the clinical approach to provoked vestibulodynia, again based on Goldstein's approach. So if we go according to his classification, the hormone-mediated type could be initially treated by stopping hormonal contraception and looking for an alternative contraception technique and using topical estradiol, maybe with testosterone, locally to the vestibule. If we think this patient has the neuroproliferative type, then topical anesthetics or other agents like, for example, gabapentin and amitriptyline cream locally can help. There are not much is evidence-based of all these medications. Vulvar vestibulectomy, as I said already, has become less popular in the last years, but it's still an option in some very refractory cases. And if we talk about the hypertonic pelvic floor dysfunction, then physical therapy, as Melanie has already presented, in combination with cognitive behavioral therapy and maybe muscle relaxants are the main and first modality of treatment.